Welcome to On Becoming a Healer. I'm Saul Wiener, and my co-host is Stefan Kertez. On the last few episodes, we've had guests on our show, and today, instead of having a guest, I'm going to be interviewing Stefan. Many of you are aware that Stefan cares a lot about the opioid epidemic, its effect on patients, particularly around the issue of suicide, and has written quite a bit about this topic. The stimulus for today's conversation is a paper that was recently published called Opioid Prescribing and Suicide Risk in the United States, and a response to that paper that Stefan published in the blog Sensible Medicine, in which he talked about some of his concerns, not just about the paper, but about the way in which the paper was interpreted as it kind of rolled out into the media. Now, today's conversation, I think, is going to be actually a lot broader than just this very specific question of the relationship between opioid prescribing and suicide. But that's where we're going to start. And I think this is really, in many ways, a starting point for talking about some of the complex challenges of caring for patients in an environment where there are a whole range of competing perspectives that shape so much of what we do, and how we kind of make our way through that morass so that we can do the right things for patients. So welcome, Stefan.
Hi, Saul.
So, Stefan, I think it would be helpful if you started by just kind of summarizing this paper for a kind of general audience, and then to talk a little bit about your reactions to it.
Yeah, sure. So this paper looked at national data, and it was taken by some in the lay press to suggest that when you reduce opioid prescriptions in long-term patients, you should not worry about a risk of suicide. And what they actually did is they just looked at regional trends in opioid prescriptions and regional trends in suicides. And just so you know, in the last 10, 12 years or so, suicides have slowly gone up for the most part, and opioid prescribing has generally gone down. So they looked at trend lines and they said, look, in the regions where the opioid prescriptions went down more, they had a little bit less of a rise in suicide in those regions. And that's pretty much what it was, a regional paper. You don't really know if the people who died by suicide are the ones who had opioids or not. It's just a regional analysis. And if that's all it was, it really would be kind of a food for thought thing. But the way it was written kind of kept talking about, hey, there's this concern about taking people off their opioids, and people have been saying maybe it's risky, and in a way our data says it's not so risky, and then the media kind of ran with it. And there was even a prominent expert who talked about the suicide hoax on Twitter. So it came across as seeming like it was minimizing the risk to those patients. There were statistical issues with the paper that I would raise in a different setting, but that's kind of what the paper was about.
Yeah, so I think, just to put this in a broader perspective, when the opioid epidemic started, we were handing out these medications like candy. By we, I mean the medical profession. At the time, everybody talked about how pain was the fifth vital sign. We should treat pain very aggressively. Then, of course, as we all know, that spurred the opioid epidemic. And then kind of the pendulum swung the other way, where all of a sudden opioids were bad, 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 and we should get everybody off opioids. And then, of course, people like you got very concerned that that pendulum had swung so far that we were forcibly tapering people, often to their severe detriment, and that it appeared that this was resulting in grievous harm for some people and even suicide. And then, of course, a paper like this comes out and it sort of starts to challenge that concern up to a point. And so someone like you who looks at this from a researcher's perspective starts to say, what inferences can we really draw from this paper? Does this paper really refute the concern that opioids could be leading to an increase in suicide? And it sounds like, you think that there are some methodologic concerns about the paper. Not that the paper doesn't have merit, it shows an association, but that we have to be very careful that we don't impute causation. One of the things that I thought was really interesting in the blog that you wrote is that you pointed out some of the potential confounders. And one of the things that you said is that in these regions of the country, as you said, the country was kind of broken up into 800 and something regions when they did the study. They found that, the ones where opioids were going up showed the greatest increase in suicide, and conversely, where opioid use was going down, the rate of suicide was going, again, it's still going up, but it wasn't going up as much. And I think one of the points you made is that there are a lot of reasons why those two things could be correlated, but not one not being caused by the other. So
Absolutely.
for instance, if a a county or a region of the country is just doing better in general. Young families are moving in, great new doctors are moving in, all sorts of areas improving economically. What would you expect? You'd expect that suicide rates would drop, and you'd expect that prescriptions for opioids would drop. It's not that one is causing the other. It's just that they're both proxy measures for good things happening in that community. Similarly, in a community that's kind of going down the tubes, where the economic situation is deteriorating, you would expect that, suicide rates would go up, deaths of despair, and opioid prescriptions would go up. So I think your point was that the fact that they are correlated truly doesn't mean causation. And so when the media ran with that and started saying, this just goes to show that we don't need to worry about yanking people off opioids because, hey, look at the data, it seems to help them, that making that leap is a big concern. Is that a fair summary?
Yeah, I want to make a couple quick points there on this. One is that when regional analyses never tell you about what happens to individuals. Imagine a study which said, hey, should we treat people who have heart attacks with aspirin, which you and I both know is a good thing to do. And the way you decided to test the question was to analyze the 50 states and their net aspirin consumption at the state level and their total heart attack death rate at the state level, and then drew conclusions from that. You'd be like, that is not the way to decide how to treat individual people who might be having heart attacks. Maybe there's a lot of other reasons aspirin's being consumed. Maybe there's a lot of sports injuries in that state that have nothing to do with the people who are having heart attacks. So that's typically referred to as ecological fallacy. And to be very fair to the author of this paper, who I spoke with before writing my blog, he offered to clarify and sent me a quote, which he had quoted, to try to back out of any implication that you should really change individual patient care based on their article. The other thing I just want to put in as a parenthetical here is when you say opioid epidemic, I usually say opioid crisis because I haven't figured out if we should view opioids as like an infectious disease agent that simply causes death and destruction wherever they go. Just so that people who follow me know that. I'm putting that on the record.
Yeah, I'm glad you pointed that out to me, and it just shows how I've been sort of wired to say things a certain way. It's like I still say, instead of saying a person died by suicide, I say they committed suicide,
yes.
even though I think it's well understood that that's not an accurate or useful way to use the term. But I'm glad you keep reminding me because the way we say these things really does matter. But again, just to go back to what we were talking about before, I really think this example, though, is helpful because we often hear people say correlation doesn't mean causation, but we also then go, yeah, but most of the time it does. And yet, I think the example you're giving here is like, no. In the way this particular study was done, in fact, it may be even more likely that these two things are just moving in the same direction.
Yeah.
Because of things that are happening in those communities, and that may be more likely than that one's causing the other.
Yeah, happy communities.
Absolutely. And so I think that's why that it's so useful to dig into these things and try to understand what's happening, to think about alternative explanations, which is what I think you did in your blog.
Yeah.
But what I kind of wanted to shift to here is the question of why is it that we struggle so much with this topic of whether we should be forcibly tapering patients who are on opioids or not. I think this has become a very contentious issue. On the one hand, you have people who are saying opioids are evil, they're bad, they're killing people, no one should be on opioids unless they have cancer, or they're in hospice, or they've just broken their leg, just very specific situations. But on the other hand, we have others, including yourself, who are saying, wait a minute, that's just overreach, and we may be causing grievous harm by the single-minded approach that so many others are advocating around just getting everyone off opioids. And I think physicians obviously are caught in that because they have to make the day-to-day decisions. And so I kind of want to explore with you what physicians should do under these conditions that are so contentious. And it may be worth starting by talking a little bit about why so many physicians and others, and including the media, would take a paper like this so uncritically and interpret it even beyond where the authors wanted it to go. Why is it that they would look at a paper like this and say, oh, and I think you actually quoted, I believe, a surgeon,
yes.
And you pulled this out of the media, who basically said, yeah, this just goes to show that there is absolutely no reason we shouldn't be taking all our patients off of opioids, which is, of course, not even
what
an
the paper said.
interpretation the authors advocate. And so I want to kind of start by asking you, why do you think that so many people want to run with this sort of dogmatic view?
So, I mean, there's a difference between the why and the intellectual case you can make for why. But the why first is I think that we're incredibly uncomfortable with uncertainty. So, if you present me with a patient who has post traumatic stress disorder and maybe some intense emotional affect that can make me uncomfortable, and they say they have pain, and I'm not entirely sure that the opioids we've been prescribing for the last 10 years are helping or not, I can't tell. And their function isn't great, although it's sort of there. I would love to have a clean way out. I would love to have a clean way out to know that what I'm doing is right and not wrong. And then there's the intellectual argument, which says, gosh, in retrospective data, there's a correlation between the dose that's prescribed and the risk of an overdose event. And if that's true, maybe you're making every patient safer when you reduce their dose. And so that also applies a little bit of force. And then lastly, there's regulatory concern. I have read regulatory rulings from medical boards, from courts, and they are incredibly simplistic. They indulge every bad instinct that I've just described. If you only know whether a urine drug test was ordered or not, you know whether that care was good or bad. So all those things weigh on us, and I think we do want simple solutions. Our psychology is to not like complexity and uncertainty.
Yeah, it's funny. When I look at the title of your blog, what sticks out for it is how boring it is.
I'm going to read it. Do you want to read it or should I read it?
Yeah, I'll read it. It says, suicide and opioids, no easy answers, no sweeping conclusions.
Yep.
It's like, makes me want to yawn, right? and yet, that's the point. Now, I think the situation that doctors are in, and you touched on it a little bit, can be thought of as at the center of a set of vectors pointing towards them in different directions. So on the one hand, there's the fear of getting censored because you prescribed opioids for somebody and you might get in trouble with your licensing board. Another one is that, if something's bad is going to happen to them and it's because I didn't take them off of opioids, that's on my watch. But if I take them off of opioids and something bad happens, well, it's not really on my watch.
Not my deal.
It's not my deal, right? And so we tend to associate those two things differently, even though if you think about it, they're both actions that we took. And ironically, keeping them on the opioid would have been the non-action, and taking them off the opioid is the action. Although the fact that they're no longer on a drug we prescribed makes us feel to some degree like it's not our
I'm
our
doing
problem.
nothing. Yeah.
Exactly. I think another part here is that we tend to feel like we can't really partner with an addict. There's a tendency to feel like they don't necessarily act in their own interest. And there's some truth in that, right? Like an addict is not always going to, or maybe less likely to be unbiased in their partnership with you around what's the best next thing for them. They could be pushing for something simply because that's part of the nature of addiction. So it makes us more inclined to distrust what the patient wants and more inclined to do what we think we're supposed to do.
Dare I challenge you, though, on your
Please
term?
do.
Okay. 2 layers of concern. Somebody with opioid use disorder, the diagnosis, might be informally termed an addict. There's a lot of dispute, and I would say I've generally veered away from that term for a person with diagnosable addiction. Then, although I'm flexing on your language choice, the point is that somebody who's dependent on something, and that thing is a controlled substance, we do want to discount what they say. We do want to say, and in fact, we might want to say, they don't have adequate understanding because their dependence, even if it's not addiction, blinds them to reality. And that is a real question. Should we say that somebody's dependence blinds them to reality? That's a question, isn't it?
Well, I think that the term addict is one of the ways in which we label people. Because when you say someone is an addict, it's a way of defining them. They are this. And which is also a way of maybe dehumanizing them is a little bit of a strong term, but it makes them less than fully a person. It brings them down to one dimension. Let's put it that way.
Yeah, that's good.
It reduces
Very
them to
well.
one dimension.
Like
Yeah,
that.
it's like calling somebody a leukemic as opposed to somebody who has leukemia. And I think where you're going with this, which I think is really important, is that we should always start from the perspective of engaging with the person in front of us, who in this case may be somebody who has an opioid use disorder. And what do I mean by engaging? Of course, we've talked about this so much in this podcast, but it just needs to be revisited, I think, which is that to engage with somebody, first of all, you have to be yourself rather than the doctor in the white coat. So if you're going to have a conversation with somebody who has opioid use disorder, and you have these fears that you might lose your license if you go along with their request that you keep them on a high dose, and you fear that you might be sanctioned, but you're not averse to having the conversation about keeping them on it because you want to do the right thing, well, then all of that should come out in your conversation with them if you are engaging. Because when you engage, you're being open with them. You're saying, I'm really struggling with this because, I understand that you want to stay on this medication because you feel like this medication is really keeping you going. And it's a very high dose that you're taking. But at the same time, I'm struggling with that because, God forbid, if something happens to you, I feel like I might be responsible. I might get in serious trouble. I could lose my license. I'm not averse to keeping you on this medication, but I really need you to understand some of the things I'm struggling with. Okay. To me, that is an example of a physician engaging with a patient. So they're putting their cards out on the table. The second component of the engagement is that it has to be on a level playing field. It has to be a situation where you're having the conversation with the patient, not from a position of greater power. Now, ultimately, you do, in fact, have greater power. I don't want to deny that. Ultimately, you're going to get to decide whether you write that script for opioids. So there's a little bit of a unavoidable here. But I think that you can make a good faith effort to let that person know that the conversation itself is going to be on a level playing field. You're not going to use your power to try to bully them to agree with you. You're going to have a conversation with that person that is truly on a level playing field. And then ultimately, you're going to make a decision because you do, in fact, have the power about whether you're going to write that prescription. But the conversation is going to be on equal terms, meaning you're going to give full accordance to what they have to say to the best of your ability and without looking down on them in any way because you're the doctor and they're the patient. And I think that is the place where these conversations, I think where all doctor-patient conversations have to occur, but really where a conversation like this all too rarely goes. And I think that might be what you're getting at when you're talking about how saying, I can't trust an addict is really the wrong starting point in so many ways for having these conversations.
Yes, I agree with what you said, and I agree with the idea that I should be able to put my cards on the table openly, and even if I have a special privilege and a special power in regard to that prescription, it should be a conversation between two people that are fundamentally equal human beings in the eyes of whoever you believe it. I still want to raise this question, though. Do we know if dependence is something that fundamentally hinders the patient's ability to understand if the thing we prescribe has been helping them all along? I can see the argument, someone saying, well, look, dependence blinds them to some essential information, and you have to discount this person because they're impaired. Again, this is not actually my point of view, but I want to push that.
But sometimes people do, in fact, overdose on an amount of medication that they took because they thought it was a safe amount, and in fact it wasn't a safe amount. So we do know that people with addiction, and of course with alcoholism,
dependence,
we know,
or just dependence,
or dependence,
even if it's not addiction,
can in fact err, right? And they can err because they have a craving. That's why they say, if you're hungry and you haven't eaten 3 meals, that's probably not the best time to go shopping, right? Because you're going to fill your shopping cart with all kinds of stuff that you may later regret and just say, that was probably a waste, or that's going to spoil. So I think that we all understand that there are circumstances under which we are not at our best in terms of exercising judgment. And I guess I would say that when somebody is craving something, whether because they're hungry or because they have a dependence on a substance, they may not always be at their best in terms of exercising judgment, in terms of what the short-term consequences might be for them of an action that they decide to take. Does that make sense?
Yes, it does, although but the words you said might lead some to more fully justify not engaging. And I don't think you want that to happen. And I
Exactly.
I want to highlight that we always meet patients under something other than their best circumstances. That's why they're patients. And we're always operating on something other than our best circumstances because we're not perfect and life is crazy and the EMR is driving me crazy. So I'm a little impaired. And they're not going to be at their best. And so I would say, and this is my pushback on the dependence argument, which I acknowledge is a real issue, and I struggle with individual patients, but I would just say, you know what? I am not sure this is a difference in kind. This is a difference. It could be a difference in degree, meaning one patient in the middle of their MI and another patient with a new knee injury but freaking out because it might kill their football career, and another patient with dependence but functional and having a job. They may all be, to a different degree and in different sorts of ways, imperfect observers of their own existence at the moment. I mean, just go to the sideline of a high school football game with a kid who just busted his knee. Will he be a perfect observer of what the hell is going on? Probably not. Or she, sorry. But we're all in, I think it's a difference in degree, not in kind.
Absolutely. And I think that's why I believe that engagement is the only way to interact with patients at all times. And of course, we've talked about the importance of boundary clarity on a number of other episodes. And that comes up when having difficult conversations with patients. But the purpose of boundary clarity is to enable positive engagement. And so I think that as long as you have that boundary clarity, engagement is the only place to be, or I should say openness to engagement, because engagement requires two people, right? I mean, I can be open to engaging and you can be unwilling to engage. But I guess what I'm saying is an openness to engagement is really the place that I think a physician should always be. And so if I were having a conversation with a patient around opioid prescribing, and that patient were on a high dose and they were insisting that they wanted to stay on that high dose, and let's suppose they were also taking benzodiazepines, and I had real concerns, and I was having a conversation with them about how I worry about them, how I'm not entirely comfortable with continuing the course of therapy they're on. That even if they want it that way, I fear for how I would feel if something bad happened to them. And if they continue to persist, I might at some point say to them, look, is it possible, I'm just throwing this out there, that maybe your judgment isn't so hot today because you haven't had this medication filled for a few days and you're starting to feel, I think, tell me if I'm wrong here, like you might be going into withdrawal, and that might be affecting your judgment. And I respect that. So I guess I would be very open with them about what I'm thinking. And so I guess what I'm saying is that's what engagement is. And if they said to me, how dare you say that? I would say, well, I'm sorry, I didn't mean to offend you, but I also wanted to be honest with you about what I'm thinking right now. How does that sound to you? Am I off base? So I guess what I'm saying is engagement is the capacity to continue to be fully present in the moment, to be yourself, to be open, and yet to do it with continued respect. Because remember, as the physician, you do have an obligation to never deviate from that respect. And respect is where you don't start becoming defensive and yelling at that person because you recognize that you have a responsibility to their well-being, but you're going to continue to engage. As you know, that's what my book on Becoming a Healer is about. But I think that that's where a conversation around opioid prescribing and represcribing needs to go. And I think that your blog post, which has this, sort of, I was put it in quotes, boring title, no easy answers, no sweeping conclusions, is really about saying, look, we, meaning our field, can't tell physicians, this is the path you should always take. And we have to be very careful about the messaging we're getting from the media, from the know-it-alls who think they have an answer, and there are quite a few of them out there who are trying to tell us opioids are good, opioids are bad, you need to taper opioids, you shouldn't, etc. That it is part of the uncertainty of being a physician, and that while we need to be well-informed and we need to be aware of the literature, that this is kind of a classic example of where that relationship and the capacity to maintain that respect with the patient and to engage, I can't think of a better example of where so much hinges on that.
Well, I want to talk about whether this culture now influences or should influence how we train. And I'm going to keep it on opioids, but because you've talked a lot about training, but I saw a new journal article that was reflecting on family medicine residents who explained that they were just afraid to prescribe opioids in general. And I was in a scientific meeting recently in the pain group, which historically is a lot of people who had tried to reduce opioids as part of their professional interest, where somebody announced, we need to have a conversation about what they called opioid phobia or opioid phobia. I don't think I said it right. And that they were kind of frustrated. Everybody was afraid. And I'm trying to figure out, if our trainees have grown up in the last 10 years seeing this crisis unfold, and they're very afraid to touch this topic of opioids or even to consider prescribing them. And I'm not saying they all should, but they're now actually in a position of fear. Is there something special we're supposed to do in the training conversations to allow that this complexity, which is a really boring and yawnable topic when I say it's complicated?
Well, let me kind of throw that back at you. We're often told that you should only prescribe opioids if somebody's broken their leg, you know what I keep saying, has this acute injury, or if they have, quote, cancer.
Cancer,
or,
yes.
Yeah, or if they're, dying.
Dead.
And let's take
Or
the
dead.
cancer one. So somehow people with cancer seem to get this special allowance where it's okay to put them on opioids. And so I guess my question to you is there something magical about cancer that's the reason that's the one place where it's sort of considered okay to put people on opioids? Or would you say there are other situations, or would you say we should never put people on opioids for chronic pain unless it's cancer pain? Like, how do you? I'm just curious, because this is something that I think our listeners might be interested in.
So first of all, the scientific data on opioids for cancer pain is about as weak as the scientific data for opioids for chronic pain, which is to say there's some evidence of benefit. We know from individuals who've said, yeah, this really helped. It's not always effective. There's not some giant set of studies that show that opioids are always wonder drugs when you have cancer and never helpful when you don't have it. And there's no biological or physiological reason to assume that opioids are uniquely effective because cells are proliferating in a certain way in a certain part of the body, and then never effective when you're not. So when you're prescribing for cancer, you're prescribing under conditions where they may be helpful. And I know everyone thinks the word cancer means you're about to die, but that's no longer the case. Lots of people live for a long time with cancer. So I wonder if that invites the kind of conversation which says it's a bit intellectually hollow to assert that opioids are somehow okay for cancer and not okay for almost anything else that's chronic. There's a rational distinction you could make based on your own personal ethics or your value system, but not based on the science. And if it is based on ethics, then I want to say, wait a second, what's the different ethical value of the patient who has cancer and is going to live for 2 years, and the patient who has heart failure, severe arthritis, complicated disability, and is going to live for you don't quite know how long? Like, are those lives really entirely different in terms of how we should think about our care for them? I think you're stuck weighing pros and cons with both cases.
Yeah, and I think that's a great example. And again, I'm curious as to what you think, but I can imagine a situation where I have a relationship with a patient and they fall into the second category, and they're really suffering. They're just in terrible pain. Let's suppose they have really bad spinal arthritis. And, we've tried lots of things. And I might say to them, well, look, why don't we put you on a little bit of, I don't know, Norco, whatever it is, pick your opioid, and let's just see how it goes. And they come back, a couple weeks later, and they're like, wow, doc, that's great. That's been so helpful. Okay. So have I made a mistake? Have I done something wrong? Am I going to regret it?
Maybe.
A year? Maybe. The answer, exactly. The answer is maybe I will regret it. But was it and because I might regret it, was it a mistake in the first place?
I don't think so. I think that we make decisions we take evidence into account, and I'm now channeling you, of course, but there is scientific evidence. There's nothing to suggest that opioids are routinely superior, and they are clearly more risky. So that's enough evidence to say you're going to get to this usually after trying other things, although not always, but mostly after trying other things. But when you take that step, it's a serious step, but I don't think you made a mistake to try it, even if it turns out at a later time you're like, shit. You got to that decision the honest way, which was by trying to figure out what to do and working through every option you had, and by engaging, as you said. And I think it's going to be the wrong decision sometimes, though. I think you have to put that on the table.
The opioid crisis didn't begin because physicians were putting patients on opioids for chronic pain. It happened because they were doing it like candy. In other words, they had bought into this idea that pain is the fifth vital sign and that you should just be throwing opioids at everything that hurts. I'm exaggerating a little bit here, but not that much. And because they were it was being heavily marketed to them. And so the mistake we're making now is thinking that simply putting anyone on an opioid for chronic pain is basically a crime, when in fact it's all about complexity and judgment and nuance and relationships and recognizing that there's uncertainty. And tell me if I'm putting words in your mouth, but I think that's where you're going with this. I know the paper is much more about taking people off opioids forcibly, but I think the other side of the coin has to be considered as well, which is, are there situations where we should be putting people on opioids for chronic pain? And I know that's a much dicier question, but I think it's one that I'm glad we're touching on today. And I think the answer is we certainly can't say that you should never do it. I think we need to say that never is a word that we may not want to use in this setting, right? That it's, unfortunately, it's all about complexity and judgment, and, well, fortunately or unfortunately, but that's the nature of doctoring.
Yeah, never's the wrong word. Real people have complicated problems. You and I have talked about the fact before on this podcast that we cannot always fix them and that they can be very severe. And if we can reduce people's feelings of disability or alarm from those problems without relying on a medication that might have risk, we should. But we're going to wind up working through complex forms of suffering a lot of the time where we can help. And sometimes that helping will involve a medication that has risk to it. I think that a lot will depend on that person. It'll depend on whether you think you can manage the medication safely. It may depend on whether that medication is going to be used alongside rehabilitative activities to help the person reduce their distress from the pain in other ways as well, in gain and function, because it may not be the med alone. Multimodal is a word we've used here before. So yeah, I'm not comfortable with the never. I recognize that the debate about when to start and whether to start probably exceeds the bounds of this particular episode. But at some level, I think if your view is, I will start for cancer and I won't start for other long-term problems, I think that's just a hollow, intellectually incoherent
Yeah,
view.
I mean, I want to make it clear to our listeners that this is not a conversation about how do you manage chronic pain. I think we all know that that's a very long conversation that's multimodal. This would be a terrible podcast episode if we were implying that managing chronic pain is about whether you put people on opioids or not. No,
Thank you.
That's really not what this is about. We know that that management of chronic pain is an incredibly important topic. A great deal is emerging about that, and it's something that we've talked about in other episodes. This is just specifically about the opioid issue. But going back to the question you asked earlier about what should we be saying to, say, family medicine residents who are feeling like they have a phobia of opioids, I think there are really two messages that are coming out of our conversation that I want to share. Actually, one of them, which we haven't really discussed, which is documenting your rationale. So I think that if you do make a decision to keep a patient on a high dose of an opioid, or even to start them on an opioid because you feel it's the right thing for the patient, given the information you have at that time in your judgment, document your rationale. I'm not an attorney, but when I've talked to attorneys, they've often said that what protects you if you are sued is that you have a thoughtful explanation for why you chose to do something, in the hopefully unlikely outcome that there's something bad that happens as a result of it.
Yeah.
And so I think that if I make a decision to keep a patient on opioids because I feel they're functioning well, that I don't want to perturb that status quo, that equilibrium, I've discussed it with them. I've given them the pros and the cons. They've explained to me why they believe that they would decompensate if we were to take them off opioids, why I feel it would be unethical to do so under the circumstance. If I document all of that, I certainly feel like I'm not only practicing medicine according to my conscience, but I'm documenting what I believe is my good judgment. And I think that prevents moral injury as well, because if I were not to do that and were to do the wrong thing and take them off of opioids just because I thought I needed to, quote, protect myself medical legally, I would feel terrible. I mean, that to me would be moral injury. That would be, I did this to cover my ass, not because I thought it was the right thing for the patient.
Right.
So I do believe that you can practice according to your conscience and document what you did, and that, again, I'm not a lawyer, but that you've done the right thing and you've protected yourself legally, at least to the best of my knowledge. And finally, I think perhaps the most important point is that all of this is about that question of engagement. It's all about the way in which you're relating to your patients. And I think that, unfortunately, we don't do nearly enough in the way in which we train physicians, even family physicians, to really talk about this concept of engagement, about learning to be comfortable being yourself, having that boundary clarity so that you are able to be vulnerable while maintaining respect, but while always being the, quote, adult in the room, no matter what happens in terms of the emotions it evokes in the other person, and realizing that that partnership is always the place for working these things out in the doctor-patient encounter.
Do you think you're being too idealistic, Saul? Do you think that somebody might say, hey, primary care is broken. Insurers, payers, it's really busy. You have to do prior authorization. I know you want us to engage, but that's going to be a 20-year project. So in the short term, we need a different thing.
The 20-year process may be right, because I think we're so far from teaching physicians what it means to be yourself in a relationship with patients. As you know, my team has audio recorded over 10,000 encounters, and it's so rare that we hear that. And so I feel, yes, unfortunately, so many of the vectors in medicine, the way we train physicians, the way we socialize them, the way we turn them into efficient task completers, are all pointing in the direction of making physicians into essentially people who are not comfortable engaging.
Yeah.
Now, on the other hand, I don't think that's what physicians are talking about when they say this is a 20-year project. They're talking about all the externalities that we need to deal with, the crisis of managed care and all that, the fact that we don't have universal access to care. All of those, I agree, are problems, but that's not what gets in the way of engagement. I can say to a patient, look, unfortunately, the bean counters only gave you 15 minutes of my time. Unfortunately, I'm going to have to end this conversation because I have another 3 patients waiting, but let's reschedule. The point is, to me, the issue of engaging is about the culture and the acculturation of physicians. It's not about all of the externalities. But I do think that we have a long way to go before physicians are comfortable having those conversations with patients on an kind of even footing, being open about what's going on, who they are, and using that as the place to work these things out.
So, to paraphrase, a response to my own question about your idealism here is, Doctor, nobody is holding a gun to your head and saying you have to wait 20 years before you act like an actual human being in the office. You could start that tomorrow.
Stefan, I couldn't have said it better.
Okay, should we close up on this point?
Yeah, I think that's it in a nutshell. I was right at the beginning when I said we were going to start by talking about something very specific, which is a paper about opioids and suicide, specifically the correlation between the two of them. And where did it take us? It took us fundamentally to this question about how, as physicians, are we relating to our patients? And in many ways, that's the core message of almost every episode of On Becoming a Healer. So Stefan, thanks for getting us there.
And thank you for letting me be the guest this time on this podcast. I'm so happy we had a chance to talk about this.
Thanks, Stefan. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have, and you haven't already subscribed, please consider doing so now. Take care, everyone.